Welcome to the Deep Dive. Today we're tackling a really important topic, hepatic fibrosis and cirrhosis. Think of it as, well, understanding what happens when the liver, our body's incredible processing plant, faces serious ongoing damage.
Yeah.
We've gone through quite a bit of detailed information to pull out the really crucial insights for you. We want to avoid getting bogged down in overly technical jargon.
Right. The goal is clarity.
Exactly. A clear, accessible understanding of these connected conditions.
And medical info, it can feel overwhelming sometimes, can it?
For sure.
So we're here to kind of distill it down, get to the essentials, the why behind what's actually happening in the liver.
Okay.
We'll explore how these conditions develop, their effects, how they're diagnosed, and, the current ways people try to manage them.
So whether you've heard these terms before or you're just curious about liver health.
Yeah, you're in the right place for a thorough exploration.
Okay, let's dive in then. We're talking about hepatic fibrosis first. Simply put, it's the buildup of scar tissue.
Like scaffolding.
Yeah, exactly. This stuff called extracellular matrix. And it starts replacing the liver's normal, healthy tissue. Then there's cirrhosis, which is, it's like the more advanced, widespread version of this scarring.
It really disrupts the whole liver structure, doesn't it?
It does. Leads to these small lumps, regenerative nodules.
That's right. And unfortunately, a decrease in the liver's ability to do its job.
Now, a key thing, you mentioned this, cirrhosis usually develops after a long period of inflammation in the liver.
That's a really critical point, yeah. Typically, it's chronic, sustained injury that drives both the initial fibrosis and its progression to cirrhosis.
But there's an exception.
There is, yeah. An important one. Congenital hepatic fibrosis, or CHF.
Okay.
This is linked to something called ductal plate malformation, DPM. And in these cases, you actually see significant scarring even without that typical history of long-term inflammation. It's different.
Right. So normally the liver gets injured, its repair mechanism kicks in. But with continuous damage, this repair process, it just goes into overdrive, right? And we end up with all this excess scar tissue.
Exactly.
Can you maybe explain a bit more about how that scarring process actually works, like the steps involved?
Sure. So when the liver is damaged, it releases various signaling molecules. Think of them like distress signals,
Okay.
cytokines, other mediators, stuff like that. They tell other cells, hey, start producing scar tissue.
Right.
Now, if the injury keeps happening, if it becomes chronic, this scarring fibrogenesis just keeps going.
And the liver tries to fix itself, too.
It does. It tries to regenerate, making new cells. That's where those nodules come from.
Oh, okay.
But because the scarring is so extensive and, frankly, disorganized, the regeneration isn't really effective. It doesn't restore normal function, and you end up with less healthy liver tissue overall.
And this scarring, it's not just the liver tissue itself, is it? It messes with the blood vessels, too.
Precisely. That's a crucial change. It happens in the liver's tiny blood vessels, the sinusoids. In a healthy liver, these are specially designed, really open, allowing easy exchange between blood and liver cells. But with fibrosis and cirrhosis, collagen, that's a protein, builds up in the spaces around them. It's called capillarization.
Capillarization, so they become more like regular capillary.
Exactly. And that hinders that efficient exchange. It also directly leads to increased blood pressure inside the liver. Sinusoidal hypertension.
Okay, high blood pressure inside the liver. That sounds like it could cause some major downstream problems.
It absolutely does. Sinusoidal hypertension kicks off a whole cascade of effects.
Like what?
Well, first, blood flow can actually start being redirected away from the liver. That's called hepatofugal portal flow.
Away from the liver. Okay.
You also get splanchnic hypertension, increased pressure in the digestive system's blood vessels.
Right.
Then the body can form these abnormal blood vessel connections, APSS we call them. They basically bypass the liver.
Bypassing the liver. That can't be good.
No. And these can have effects throughout the whole body. Importantly, this can also contribute to neurological issues, specifically hepatic encephalopathy, or HE.
Hepatic encephalopathy, right? Where the liver isn't filtering toxins properly and it affects the brain.
Exactly that. The liver's struggling and the brain feels the consequences.
Wow.
And there's more. That high pressure in the digestive system's vessels, it causes blood to pool there.
Pool in the gut.
Yeah. This pooling reduces the effective blood volume circulating elsewhere. The kidneys sense this low volume.
And they react.
They react by retaining sodium and water, trying to boost the volume back up.
Ah, and that leads to?
That's a major contributor to ascites, the fluid buildup in the abdomen.
Got it. ascites.
And finally, those fragile high-pressure vessels in the digestive system, they're at a much higher risk of bleeding, enteric bleeding.
Okay, the core issue is these tiny blood vessel problems just wreck the whole exchange system.
Fundamentally, yes. That vital exchange of nutrients, oxygen, waste products, it's all severely impaired between the blood and the liver cells.
It's really striking how a problem seemingly in one place, the liver, can just ripple out everywhere.
Yeah.
Let's dig into those ripple effects more. How does this liver damage hit other body systems?
Yeah, connecting it all up, the gastrointestinal system is directly hit by that portal hypertension. So you get the ascites and the risk of enteric bleeding, like we just discussed.
Okay, yeah.
Then the neurological connection, HE, because the liver can't clear toxins effectively.
And the effects on the blood itself were kind of surprising when I read about it.
They are quite varied, aren't they? Those abnormal blood vessel connections, the APSS, they can actually lead to smaller red blood cells. Smaller red cells. Why?
It's complex, related to iron metabolism changes and the shunting. Then you get bleeding tendencies, partly because the damaged liver isn't making enough clotting factors.
Okay, that makes sense. Less clotting factors, more bleeding.
Yes, and often a low platelet count, too. But here's the twist.
Uh-oh. Counterintuitively, the reduced levels of the body's natural anticoagulants, also made by the liver, can sometimes increase the risk of blood clots.
Wait, hang on. So less clotting factors and less anticoagulants, and that can mean more clots.
Precisely. It's a weird balance. The bleeding risk is definitely there, but in some situations, the lack of natural anticoagulants can actually tip things towards clot formation. It's complex.
That is definitely not intuitive.
Okay.
What about the kidneys? You mentioned them reacting earlier.
Yeah, the renal and urologic systems feel it too. We can sometimes see specific crystals forming in the urine ammonium biurate crystals.
Ammonium biurate.
Okay. And the kidneys might lose their ability to concentrate urine properly. That's called isostenuria.
And that causes
Increased urination and thirst.
Yeah.
Because they just can't hold on to water efficiently.
Makes sense.
And then in rare but serious cases, especially sometimes after draining a lot of ascites fluid, a condition called hepatorenal syndrome can develop, where the kidneys start to fail.
Wow. Okay. And it doesn't stop there, does it? Something about blood sugar. Breathing.
That's right. Endocrine and metabolic issues. In very late-stage liver failure, really end stage, you might see low blood sugar, hypoglycemia, usually if the animal isn't eating.
Okay.
Respiratory signs. Well, if there's a lot of ascites fluid pushing on the diaphragm, it can cause rapid breathing.
Yeah?
Tachypnea.
Just from the pressure.
Yeah. And rarely, fluid can even build up in the chest or lungs. And then there's a skin finding, too, a specific type of superficial skin inflammation, necrolytic dermatitis.
So it really does touch almost every part of the body. Which brings us to, well, who gets this? Are there specific risk factors or predispositions, genetics involved?
Absolutely. Genetics definitely play a part. We know certain dog breeds have a sort of familial tendency for chronic hepatitis, which is often the precursor.
Which breeds?
Breeds like Dobermans, Cocker Spaniels, Labs, Maltese, and Bedlington Terriers are classic examples, specifically related to copper metabolism.
Right, the copper issue.
Yeah, they have a genetic defect in how they handle copper, leading it to build up in the liver and cause damage.
And how common are fibrosis and cirrhosis overall?
They're, well, relatively common in dogs that have ongoing liver inflammation, chronic hepatitis. Also in animals with long-term blockage of their bile ducts. And in those dogs with that excess copper accumulation, whether genetic or sometimes dietary.
You mentioned specific breeds. Can we unpack that a bit more, the typical signalment, as vets call it?
Sure. So cirrhosis is commonly seen in dogs with chronic hepatitis. In cats, it's often linked to chronic inflammation of the bile ducts, cholangitis or cholangiohepatitis. And in both species, long-term bile duct obstruction can lead to it.
Okay.
Severe fibrosis, especially the type linked to that ductal plate malformation and congenital hepatic fibrosis, the DPM-CHF thing,
Yeah.
that affects both dogs and cats.
And the copper connection again.
Right. Besides Bedlingtons, we see increased risk in Labs, Dobermans, Dalmatians. But honestly, any breed can be affected by copper issues, sometimes just from high levels in the diet. It's not solely genetic.
Good point. Any other breeds or species notes?
Boxers might have a higher chance of developing that DPM-CHF condition. And interestingly, cats with polycystic kidney disease, PKD, they also seem to be at increased risk for liver fibrosis.
What about age? Does it tend to hit older animals?
Generally, yes. Cirrhosis is more often diagnosed in middle-aged to older dogs, but, and this is important, it can occur at any age, especially if copper accumulation is involved.
And cats.
In cats, biliary cirrhosis, the type linked to bile duct issues, often affects cats older than 7 years. And the fibrosis from DPM-CHF, that's thought to just get progressively worse with age.
Any gender difference?
Some evidence suggests male Cocker Spaniels might have a higher incidence of chronic hepatitis leading to it, but for Dobermans, Labs, or the DPM condition, there doesn't seem to be a clear sex link.
Okay, so what are the actual causes? What kicks off this damage in the first place?
It's quite a varied list. Chronic inflammation is a huge one. That could be immune-mediated, where the body's own immune system attacks the liver.
Autoimmune-like.
Sort of, yeah. Or it could be ongoing damage from things like oxidative stress. Copper accumulation, we've hit that one hard, often genetic, not always. Then there's exposure to certain drugs or toxins. Some anticonvulsants, like phenobarbital over the long term in dogs.
Really?
Yeah. Certain antifungal drugs, the azoles. NSAIDs, especially carprofen in dogs, have been implicated. And environmental toxins, too.
What kind of toxins?
Things like aflatoxins from moldy foods, certain mushrooms, blue-green algae.
Okay. Infections.
Yes, infections like leptospirosis or canine adenovirus can cause liver damage that might become chronic. In cats, that chronic inflammation of the bile ducts is a key factor.
And blockages.
Prolonged obstruction of the bile duct, yeah, in both species. And sometimes even a single really severe liver injury from a potent toxin, think sagopalm or xylitol.
Xylitol, the sweetener.
Yes, highly toxic to dogs' livers. A massive insult like that can sometimes trigger fibrosis down the line, even if the animal survives the initial poisoning.
Wow. So are there specific risk factors that just make an animal more likely to head down this path?
There are. We've touched on most. Breed predispositions are a big one. High dietary copper intake. Interestingly, iron buildup in the liver can also be a risk factor in some cases.
Iron too.
And then any condition causing that chronic inflammation of the liver or bile ducts or long-term bile duct obstruction, those just inherently raise the risk.
And you mentioned phenobarbital and carprofen.
Yes, long-term use of phenobarbital in dogs and NSAIDs like carprofen, particularly maybe with higher doses or longer durations, are considered risk factors.
Okay. Given that the early signs are often so vague, how do people even start suspecting this? What are the clues?
That is a real challenge. The early signs are often quite general, non-specific, things like just being tired, lethargic.
Not themselves.
Exactly. Poor appetite, maybe losing weight gradually. These could point to so many things.
Right.
It's often only as the condition progresses that we start seeing signs more clearly linked to that portal hypertension we talked about.
Like the HE, the ascites.
Precisely. The neurological signs of HE, the fluid buildup in the abdomen, ascites, maybe signs of bleeding from the gut, or signs directly related to the liver just not functioning properly.
What might an owner notice at home over time?
Well, beyond the lethargy and poor appetite, maybe some vomiting, diarrhea, or even constipation. Later on, or if those APSS develop, they might see that dark, tarry stool melena.
From bleeding in the upper GI tract.
Exactly. Increased thirst and urination can be a big clue, too, linked to that kidney issue, isostenuria. The late onset of ascites is a major flag. Any changes in behavior or mental state suggesting HE, jaundice, the yellowing, that's actually more common with the acquired inflammatory types of liver disease, less so with the DPM-related fibrosis, interestingly.
Okay. Any differences in cats?
Yes, ascites is generally less common in cats with typical acquired liver disease, but you do see it more often with DPM in cats. And for HE in cats, the signs can be a bit different side. Owners might report excessive drooling, sometimes aggression, or even seizures.
Drooling, that's unusual.
It is, but it's a recognized sign of HE in cats sometimes.
And what might the vet pick up on during a physical exam?
Well, they might confirm the lethargy, poor body condition, maybe a dull coat. Jaundice and ascites, if present, are obviously key findings. They'll be looking carefully for any neurological abnormalities suggestive of HE. Feeling the abdomen, they might detect an enlarged liver early on or a small irregular liver later in cirrhosis.
Right.
Clotting issues are variable, maybe less common clinically with DPM, and they might spot that specific skin lesion, the superficial necrolytic dermatitis, though it's not super common.
And rarely generalized swelling.
Anasarca, yeah. Very rare. Sometimes linked to aggressive fluid therapy if albumin is very low.
So if these signs are pointing towards liver trouble, What else could it be? How do you narrow it down?
That's the differential diagnosis step, yeah. And it's crucial because lots of things can look similar.
Like what in dogs?
In dogs, you'd consider other forms of chronic hepatitis, non-cirrhotic portal hypertension, which is high pressure without the cirrhosis, maybe a chronic bile duct obstruction that hasn't progressed fully yet.
Okay.
Chronic gut inflammation, like IBD or chronic pancreatitis, can sometimes cause similar signs. Liver cancer, primary or metastatic. Congenital issues like portosystemic shunts.
Right.
And even sometimes severe right-sided heart failure can cause liver congestion that mimics primary liver disease.
And in cats?
In cats, you'd think about hepatic lipidosis, fatty liver, definitely FIP, feline infectious peritonitis, maybe toxoplasmosis, sometimes even severe hemolytic anemia causing jaundice.
So quite a list. It's real detective work then. What tests help cut through the possibilities?
Yeah, it takes a combination. Blood work, urine tests, other lab analyses are vital first steps.
What do you look for in blood work?
You might see those smaller red cells, the microcytosis, especially if APSS are present, mild anemia maybe. Liver enzymes, ALT, AST, ALP are often elevated early on, sometimes quite high, even before obvious signs.
But not always.
Right. In very late-stage, end-stage disease, the enzyme levels might actually start to drop because there's just not much functional liver tissue left to leak enzymes.
Oh, okay. What else?
Low albumin is a big one, shows the liver isn't making enough protein. Globulins, another type of protein, might be high due to chronic inflammation. Cholesterol and BUN levels can sometimes be low.
Low BUN and cholesterol. Why?
Liver makes BUN from protein breakdown products and is involved in cholesterol metabolism. So poor function means lower levels. Bilirubin can be high, causing jaundice, but it's variable. And potentially low blood sugar late stage.
And the urine tests.
That's where you might see the lack of concentration, the isocynuria, and those specific ammonium biurate crystals we mentioned.
Mm-hmm. Any other lab tests?
Absolutely.
Yeah.
If there's fluid in the abdomen, analyzing that acidic fluid gives clues. Is it protein-rich, cell counts, etc.? Coagulation tests like PT and PTT might show prolonged clotting times. And functional tests like serum bile acids or ammonia levels are often elevated, showing the liver isn't doing its job clearing these substances.
Okay. What about looking inside? Imaging.
Very helpful. Abdominal x-rays might show a small liver or maybe ascites, though the fluid can hide details. Sometimes certain urinary stones are visible, but not usually the ammonium biurate ones unless they're mixed.
Ultrasound seems key here.
Ultrasound is often very useful, yes. It can show changes in the liver's appearance, texture, brightness, maybe nodularity. It confirms abdominal fluid. And crucially, using Doppler, it can help identify those abnormal blood vessels, the APSS, and assess blood flow direction in the portal vein.
Can it look normal even if there's disease?
Sometimes, yes. Especially early on or with certain types of fibrosis, the ultrasound might look deceptively normal, so a normal ultrasound doesn't completely rule it out.
So blood tests and imaging give strong hints, but they aren't the final word.
Often not for a definitive diagnosis of the type and severity of the liver changes. For that, you usually need a liver biopsy.
A biopsy, taking a piece of the liver.
Exactly. Fine needle aspirates, just sucking out some cells, can rule out things like obvious cancer or infection, but they don't give you the architecture. They don't reliably show fibrosis or inflammation patterns.
So you need a bigger piece.
You need a core biopsy, yeah. A small piece of tissue that shows the structure, usually done with a larger needle, maybe 14 or 16 gauge, or surgically.
Surgically?
Laparoscopy, keyhole surgery, is often preferred. It lets the vet actually see the liver surface, look for abnormal vessels, and take targeted biopsies from different areas or any suspicious spots. It gives the best samples, usually.
Okay, so let's say we've gone through all that and the diagnosis is confirmed. Fibrosis or cirrhosis.
Mm-hmm.
What then? What are the treatment approaches, the management strategies?
Right. And it's important to set expectations here. For advanced fibrosis, and especially cirrhosis, treatment is often palliative.
Meaning focused on symptoms and quality of life, not cure.
Exactly. We're managing symptoms, managing complications, trying to slow things down rather than reversing the established scarring.
Are there drugs that can reverse scarring? Antifibrotics?
There's research into them, and some are used, but honestly, the evidence for significant reversal in animals is still pretty limited. The most important thing, the real cornerstone, is trying to identify and control whatever caused the liver injury in the first place.
Stop the ongoing damage.
Yes, because that's the best way to slow down any further fibrosis. So management really focuses on a few key things. Treat the underlying cause if possible, manage the ascites, manage the HE, and generally support the liver's remaining function.
And medications are a big part of that.
A huge part, yeah. They target all those different areas.
You mentioned managing HE specifically earlier. How's that done?
It involves identifying and minimizing triggers. Diet changes are common, often lower protein, but specific types of protein. Medications like lactulose are crucial. It helps trap ammonia in the gut so it doesn't get absorbed. Sometimes antibiotics like metronidazole are used carefully too.
Okay. What about actual surgery? Is that ever done for the cirrhosis itself?
Not really for the cirrhosis itself. Surgery in these patients is generally very high risk. Anesthesia is tough because the liver metabolizes many anesthetic drugs. Bleeding risk is high due to poor clotting factor production and maybe low platelets. Even minor procedures can bleed excessively.
So you avoid it if possible?
Generally, yes. If surgery absolutely has to be done, say for a biopsy or maybe to ligate large shunting vessels in specific cases, it requires careful planning. Gas anesthesia like isoflurane is preferred. Intensive post-op care is vital, managing HE risk, hydration, electrolytes.
Infection risk.
Yeah, there's thought to be increased risk of bacteria moving from the gut into the bloodstream, bacterial translocation. So antibiotics might be used carefully around GI or biliary surgery.
Got it. So back to medications. What are the main categories and specific drugs people use?
Okay, so if you find a specific cause, you treat that first, like copper chelators drugs like penicillamine or trientine if it's copper accumulation.
Makes sense.
If it's thought to be immune-mediated, then immune-modulating drugs are used. Prednisone or prednisolone are common, usually starting higher and tapering down to the lowest dose that works.
Steroid.
Yep. Sometimes azathioprine is added in dogs to help lower the steroid dose, but you have to monitor blood counts, and it's a definite no-go in cats, very toxic to them.
Okay. What about drugs targeting the fibrosis itself?
This is where those antifibrotics come in, though again, evidence varies. Things like same S-adenosilmethionine, silibinin from milk thistle, vitamin E, or sodiol, a bile acid. These have antioxidant or protective effects. Polyunsaturated phosphatidylcholine is another. Colchicine used to be talked about, but benefit seems limited and side effects can be an issue.
Any newer approaches?
Angiotensin receptor blockers, ARBs, like losartan or telmisartan, are being explored and used by some specialists. They block a pathway involved in activating scar-producing cells and might have other benefits on blood pressure within the liver.
Do they need monitoring?
Oh, yes. Blood pressure, kidney function, potassium levels need careful watching with ARBs.
And general support, antioxidants, liver protectants.
Yeah, definitely. SAMe and vitamin E are common antioxidants. Ursodiol, vitamin E, CA, silibinin are often used as general hepatoprotectants. Elemental zinc might be added if testing shows a deficiency.
What about stomach protection? If bleeding is a risk?
Yes, if there's evidence or high risk of GI bleeding, then gastroprotectants like proton pump inhibitors, omeprazole, or H2 blockers, famotidine, maybe sucralfate might be used.
Okay. And tackling the big complications, ascites.
Right. Ascites management starts with restricting activity and, crucially, sodium intake, low sodium diet. Then diuretics are usually needed. Typically a combination of furosemide, Lasix, and spironolactone.
Why both?
Furosemide is potent but loses potassium. Spironolactone is weaker but helps retain potassium, counteracting the furosemide effect and having some other beneficial actions. Doses are adjusted based on response, monitoring kidney values and electrolytes.
Can they stop working?
Sometimes the ascites becomes resistant. Diuretics might be used intermittently, like a few days on, few days off, to manage chronic fluid. If it's really severe and unresponsive, draining the fluid therapeutic abdominocentesis might be done.
Though carefully.
Very carefully. Removing large volumes too quickly can cause circulatory problems or trigger HE. Sometimes plasma or albumin infusions are needed alongside. There are newer drugs, vasopressin antagonists, but limited data in pets currently.
And coagulopathy, the bleeding tendency.
Often managed with vitamin K supplementation, especially if bile flow is obstructed, and just being very careful to avoid trauma or unnecessary procedures. Monitoring clotting times.
Okay. Are there any medications that are definite no-nos? Things to absolutely avoid?
NSAIDs are the big one, generally contraindicated.
My God.
Increased risk of GI bleeding, potential to worsen ascites by affecting kidney blood flow and sodium handling, and some can be directly toxic to the liver, especially if copper is involved. Best avoided.
What about precautions with other drugs? Things to use carefully.
Definitely. Diuretics need caution. Dehydration or electrolyte shifts can worsen HE significantly. Glucocorticoids, steroids, increase infection risk, bleeding risk, can cause fluid retention, protein breakdown, and also worsen HE.
And drugs processed by the liver.
Huge point. Any drug primarily metabolized by the liver might need a dose reduction. The liver just can't process it normally. Metronidazole, the antibiotic often used for HE, is a classic example. It needs a lower dose in liver patients to avoid neurotoxicity.
Are there alternatives sometimes if a standard drug is risky?
Sometimes. For instance, if ascites is bad and you need a steroid, dexamethasone might be considered over prednisone because it has less effect on sodium-water balance. For immune suppression, mycophenolate might be an alternative to azathioprine, especially in dogs, or if azathioprine isn't tolerated.
Once you start treatment, what kind of follow-up is needed? How do you track progress?
Regular monitoring is key. Periodic blood tests are standard checking liver enzymes, though they might not perfectly correlate with function late stage. Albumin, BUN, cholesterol, bilirubin, tracking body weight, body condition score, and measuring abdominal girth if ascites is present are really important practical measures.
And checking for drug side effects.
Absolutely. If they're on azathioprine or mycophenolate, regular blood counts, CBCs, are needed to watch for bone marrow suppression, monitoring kidney values and electrolytes with diuretics or ARBs.
Do you keep checking bile acids?
Interestingly, studies suggest that once the diagnosis is made, repeatedly checking bile acids doesn't really add much useful prognostic information. Clinical signs and other blood work are usually more helpful for monitoring progress.
What are the potential bumps in the road? Complications that can still arise?
Despite best efforts, complications are common. Flare-ups of HE. Infections, they seem more susceptible. Bleeding episodes. And in some, a severe clotting crisis called DIC, disseminated intravascular coagulation, can occur, which is often, sadly, a terminal event.
So what can owners generally expect? The long-term picture, the prognosis.
It's variable, honestly. Animals might have periods of stability punctuated by flare-ups of HE or worsening ascites that need hospitalization and treatment adjustments.
So ongoing management is key.
Yes. Managing ascites often requires tweaking sodium restriction and diuretic doses over time. The natural progression in dogs, especially, isn't always clearly defined or predictable.
Does ascites mean it's really bad?
Generally, yes. The presence of ascites usually indicates pretty severe advanced disease. But, that said, with DPM cases, sometimes survival can be surprisingly long, even years after diagnosis.
And even with acquired cirrhosis.
With dedicated, careful, consistent management, some animals with cirrhosis can definitely survive and maintain a decent quality of life for several years, sometimes even 5 years or more. It depends heavily on the underlying cause, the severity at diagnosis, response to treatment, and managing those complications.
Okay, so let's try and wrap this up. To recap our deep dive today. Hepatic fibrosis and cirrhosis are serious outcomes from significant, usually ongoing, liver damage and scarring.
Scar tissue replacing functional tissue.
And these conditions have really widespread effects, don't they? Because the liver does so much,
Right.
and blood flow gets disrupted.
Absolutely. Affecting digestion, brain function, blood clotting, fluid balance, you name it.
We learned the early signs can be tricky, often vague. But later, you might see more specific things like ascites, neurological issues, bleeding.
Right. And diagnosis relies on putting together clues from blood tests, imaging, and often, crucially, that liver biopsy.
And treatment, while often palliative, focuses on managing symptoms, tackling complications like HE and ascites, and most importantly, trying to address any underlying cause to slow things down.
That's a great summary. And hopefully, as you've heard, while the details get complex, understanding those core processes, the scarring, the hypertension, the impaired function, gives you a much clearer picture of why these conditions are so serious and have such wide-ranging effects.
Yeah, the liver's amazing in its ability to heal, but chronic injury really takes a toll.
It does. The consequences become systemic, multifaceted.
It really drives home how interconnected everything in the body is. And it makes you appreciate the complexity of managing these chronic diseases and the ongoing research trying to find better ways.
Well said.
Thanks for joining us for this in-depth look. Until our next deep dive, keep exploring the world around you.